present about the histological and molecular biomarkers for risk stratification in oral squamous cell carcinoma. As we know, according to the National Cancer Institute, oral squamous cell carcinoma belong to the wider group of head and neck squamous cell carcinoma and the wider group of head and neck cancer in general, that are cancer that line the moist mucosal surface inside the head and neck. This wider group is referred as a squamous cell carcinoma of the head and neck area. And as we can see from this image, this anatomical area is characterized by very different and heterogenic anatomical structures that pose a very high challenge in the treatment of such disease. I'm referring about to clinical surgical treatment and the clinical treatment with the radiotherapy, for the example. As we know today, an estimate of about 600,000 new cases of head and neck cancer are annually diagnosed worldwide. And this group of cancers are characterized by a very high mortality rate of about 380,000 deaths in the world. According to the National Comprehensive Cancer Network, this group of disease can be differentiated according to both anatomical and molecular level in other different subtype. Among these, we have cancer of the lip, for example, cancer of the oral cavity, which is the cancer I'm focusing on in this presentation. And you can see that a molecular subclassification up to date is present just for oropharynx cancer, where we have P16 negative oral head and neck oropharyngeal squamous cell carcinoma, and P16 positive that are characterized by the infection with HPV, the human papillomavirus. Focusing on the histology, we know that 90% of this cancer are squamous cell carcinoma in their histology, while 7% are adenocarcinoma. For this, we have other anatomical structure, but not in the oral cavity. And much less common are sarcomas and, for example, mucosal melanoma. The treatment approach for oral squamous cell carcinoma is much more surgical. In fact, when diagnosed in early stages, patient can be successfully managed with single modality surgical therapy. Instead, for locally advanced disease, there is the possibility today to approach the patient with both radiotherapy, chemotherapy, and more recently also with the immunotherapy on all other type of biological agents like anti-monoclonal antibody. Today, I'm going to focus on the prognostic side and the prognostic researches in head and neck squamous cell carcinoma, and more particularly in oral squamous cell carcinoma. And the basis, the methodological basis of prognostic research in this field has been developed and standardized in 2013 from the PROGRESS research group, that is the Prognostic Research Strategy Group, who proposed a framework dividing and splitting the studies from the prognosis in general in medicine in 4 different types. The first group of studies is related and are called the fundamental prognostic research, and focuses on the course of health-related conditions in the context of the nature and quality of current care. For example, we can understand which is the mortality rate of this disease in the society, in the world, and how it is related to the system, the health system of a particular nation, of a particular country. In particular, we know generally that oral squamous cell carcinoma is present worldwide, but it's much more present in some countries, like, for example, India, Pakistan, and other country of Eastern country. It is less common in the Western country, in Europe, and in the US, but it's good to say that the rate of incident is increasing also in these countries. It is characterized by a very high mortality rate, although it is also in this case there is a difference in the mortality rate among different countries, and this is also related to the capability of the health system to diagnose very early and treat very early the disease. What we know today is that if this disease is diagnosed at an early stage, the probability of survival for a patient is high, about 80–70% for stage 1 and 2, while it tends to decrease very fast for patients diagnosed at later stage. This is because of the possibility to surgically remove the whole tumor bulk and to let the patient to a tumor-free status. The second type of studies for the progress framework are studies focusing on prognostic factor research, and what I'm mainly working on in my research activity. And this kind of study for specific factors, such as biomarkers that are associated with the prognosis. We know we search for specific factor that, if present in a group of tumor, can let us understand and let us detect a more aggressive disease compared to the other group of tumor. We are talking about tumor of the same histology, from the same anatomic area, that are apparently very similar, but we know today that both histologically and molecularly they are different, and this can lead to a different clinical behavior. It's important to understand what is considered a biomarker, and according to the FDA in the BEST, the biomarker endpoints and other tool research, it is defined as a characteristic that can be measured as an indicator of normal biological process, pathogenic process, or response to an exposure or intervention, including therapeutic intervention. In particular, we can have different type of biomarker, like, for example, diagnostic biomarker, that, if present, can help us to diagnose a disease. Susceptibility risk biomarker that are more common, for example, in breast cancer. We know if patient has a specific mutation, it can develop more commonly a specific subtype of tumor. Then we have prognostic biomarker, predictive biomarker, and for example, monitoring biomarker like the PSA in prostate cancer. What is different for prognostic biomarker compared to the other type of biomarker? That in the case of cancer prognostic biomarker, we usually refer to survival analysis. And for survival analysis, we mean that we are trying to predict what will happen in the future, starting from a baseline characteristic of the patient. To do so, we usually perform some statistical analysis, like, for example, Cox regression analysis. And it's important to specify which is the outcome of the analysis. We have different outcomes. I'm showing you on this slide that are the most commonly used, like overall survival, focusing on the cause of death, or disease-specific survival that focuses on the cancer-specific death. And then other kind of outcomes like disease-free survival, much more focused on the possibility of relapse, and progression-free survival that focuses much more for advanced stage, in this case, for the possibility to have a progression or a stable disease. Mainly, I tried to categorize different kind of biomarker and the prognostic biomarker. And mainly we have histological biomarker that we already use in our clinical practice, and molecular biomarker, molecular biology, that we hope will soon enter in the clinical practice. But today they are not still present in the clinical practice. Focusing on the histological biomarker, the main type, the most important is still considered the stage at the time of diagnosis. And recently it has been updated, and we know that stage 1 and 2 have much more probability of survival, and this probability, this capability to predict has been improved after the inclusion in the new edition of the AGCC staging of TNM staging of the depth of invasion in the framework. We know today that for T1 we consider tumor with a diameter lower than 2 centimeters and a depth of invasion lower than 5 millimeters. In the 7th edition, we didn't have the focus on the depth of invasion, but just on the surface diameter of the tumor, apparent apparent diameter, because we cannot really detect the real extension of the tumor. And this has led a very better stratification for patient. Another improvement is related to the neck and the inclusion of the parameter of extranodal extension in the N category. So the staging for the N node parameter now also take into consideration the possibility of the extranodal extension, the capability of the tumor to invade the nodal capsule of the lymph node. Also, in this case, for N0 and N1 and N3, there is a good separation of the Kaplan-Meier curve, while still remain a not good separation for the different type of N2 patient. In addition, we know that we have the tumor stage that is related to the time when we perform diagnosis. So it depends to at which stage we detect the tumor, make diagnosis. But there is also something different related to the aggressiveness of the tumor. And for this, has long been used the grade system. But the grade system is good in prognostical stratification for this kind of tumor, the WHO. So some colleagues in Helsinki have tried to improve this grading system by adding another parameter, not just the differentiation of the tumor, but also include the capability to invade the underlying connective tissue. And this is the tumor binding that is defined as the presence of single cancer cell or clusters of clusters of cell than less than 5 at the vascular front, seems to improve the prognostic stratification when added to the G. In particular, they have revisited the grading system, adding including also the tumor binding into the classification. So now we have G1, for G1 well differentiated and cohesive tumor, for G2 moderately differentiated and or slightly dissociated, so there is not a very high grade of tumor binding. And for G3 we have poorly differentiated or really dissociated tumor, and they've seen they've showed has this led to a very good improvement in the prognostic stratification of this patient, and we hope it will. We have also confirmed this data on our cohort of patients in Foggia, and we hope soon this can be adopted and used in the clinical practice. Another very interesting parameter is related to the immunitary system, how the immunitary system of the patient can respond to and fight against the cancer cell. We know for colorectal cancer, this immunoscore, that is a score ranging from 0 to 4 based on the type of different type of immunity population and lymphocyte population present in the tumor sample, in the histological sample, has already been adopted in the clinical practice. So we start to study this also for oral cancer, taking into consideration what Chen and Melman published on Nature in 2017, and they classified the tumor in 3 different types according to the so-called cancer immunity cycle. We know that there is a cycle that led the immunity system to fight and kill cancer cells, and if we have inhibition of the different 7 phases in different phases of the cycle, we can have a different type of tumor, so-called tumor phenotype. If there is a good response, we have immune inflamed tumors where there is a huge, big amount of lymphocyte fighting against cell, or we can have, for example, in the immune excluded tumor, high number of cells, but they are not able to infiltrate the tumor, just remain outside in the tumor stroma, and this is called immune excluder. Or we have a subgroup of tumors, so-called immunodesert or immune cold, where there is really a paucity of cancer cells, very few immunity cells. Sorry. And we studied this on our cohort of 211 tongue cancer sample, and we tried to classify tumor according to the Chen and Melman classification based only on histological evaluation, and we found that yes, it is very difficult to differentiate between inflamed and excluded tumors, but it's very easy to classify immune desert tongue squamous cell carcinoma. And in particular, we found that this last kind of group of tumor, the immune desert, is really characterized by a worse survival rate, both for time to relapse, that for time to death. So overall survival and disease-free survival. And we hope this also will be soon included in the clinical practice, because similar results have been obtained also for other group of research worldwide. From the molecular biologic side, conversely to what has been found for other tumor, head and neck squamous cell carcinoma have been mainly classified in 2 main types: HPV positive, where we have wild type TP53 that have a favorable prognosis, and where the action inactivation of TP53 is related to the production of the E6 and E7 proteins. But we know that this kind of subgroup of tumor is not present in the oral cavity, but it's much more confined to the oropharynx. And for HPV negative, we can just distinguish the wider group with high chromosomal instability, similar to colorectal cancer, where we have a lot of aneuploidy, mutated TP53, and many numerical changes of the number of chromosomes, while a less common group of tumor with low chromosomal instability that has few numerical changes in the chromosomal number. About very often these tumors are diploid, and TP53 is not mutated, and they seems to have a better prognosis. So, but this has not really an important function in the clinical practice. According to in the 2018, this has been also confirmed after the that the studies on the cancer genome atlas database that we know is the biggest study both that allow to perform a multi-omic study for this kind of tumor. These are free data that everyone can access. From the gene expression data, we know that there are a lot of proteins that seems to be correlated with the prognosis, but we are really still in an early phase, and no one of these has been confirmed in a prospective study and can still be used in the clinical practice. Another kind from the gene expression side, another very interesting approach is related to gene expression signature that can be defined as a single or combined gene expression alteration with the validated specificity in terms of diagnosis, prognosis, or prediction of therapeutic response. Here you can see some of these gene signatures that have already entered the clinical practice for breast cancer, like MammaPrint, Oncotype DX, Prosignar. They usually focuses on a group of markers, of biomarkers, and a prognostic model is, or a prediction model is developed, giving to the physicians a high risk or a low risk for response to a particular treatment. So there is a categorization, dichotomic categorization after a complexity that is present to allow the physician for an easier approach. However, no one of these has been still developed and validated related to head and neck squamous cell carcinoma, and in particular oral squamous cell carcinoma. So according to this study, we are still not more has changed in the last year, also due to the pandemic that has slowed study on this field for the use of gene expression signature in the clinical practice. So after discovering prognostic biomarker, the third group of progress research focusing on the development and validation and debug of statistical models that predict individual risk of a future outcome. So we are not talking about ortho patient, but we are focusing on the personal probability to have an outcome for the single patient. And for this kind of study, usually this could be very interesting in the future if we are able to bring this to the clinical practice. We have the development of prognostic model using more prognostic biomarker. They can be both histological or molecular, and to allow an easier understand. Some tools have been developed. This one is one of these that we developed in 2020. It's a nomogram. The nomogram is just a prognostic, clinical representation of a prognostic model where, for example, age, tumor stroma ratio, perineural invasion, gender, and stage of the patient are put together and can be used by physicians to calculate the probability of 5-year survival, or for example 3-year survival for a specific patient. Another approach is related to the development of web-based tools. That this is one developed in Helsinki, and that is freely available for tongue cancer. And also this is based on more prognostic factors that are put together in prognostic model and that can be freely accessed and used to quantify the specific probability of survival, or in this case recurrence, for each patient. Then the last study will be the use of prognostic information to help tailor treatment decision to an individual or group of individuals with similar characteristics, and is called stratified medicine research. So the final outcome of this study is to perform and test personalized the treatment approach. This is called the precision medicine and is understood as a medical approach in which patients are stratified based on their disease subtype, risk, prognosis, or treatment response using specialized diagnostic techniques. So the idea is to use this biomarker to find a subgroup of patients and to tailor treatment protocol for this patient, but this is they are not still used and very common for all of squamous cell carcinoma, but we hope they will be much more commonly used and performed in the near future. Thank you for your attention.